Good afternoon, everyone, or good morning to you, depending on where you are in the country. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Thank you so much for attending this webinar, a home-based approach to prevent manage diabetes among the aging population and people with disabilities living in HUD-assisted facilities. Next slide, please. Before we get started, some housekeeping items. At this moment, everybody is muted. If you have any questions, please, you can ask your question. You can type your question in the chat box feature. You can also use the raise hand icon, and if your line will be unmuted. At this moment, the webinar is being recorded, and slides, recording, and any other resources will be sent to all participants via email. Next slide, please. The National Center for Health in Public Housing is funded by HRSA to provide training and technical assistance to community health centers. We focus on health centers located in or immediately accessible to public housing. However, the training and technical assistance activities are for all health centers, and all activities, including this one, are recorded, and you can also visit our website, www.nchph.org, where you can find the recording, the slides, and other resources. Next slide, please. In 2021, 1,373 health centers reported to service over 30 million patients. 458 of these health centers were located in or immediately accessible to public housing, and in 2021 they served 5.7 million patients. 108 of these health centers are public housing primary care grantees, and in 2021 they serve over 900,000 patients. Next slide. In case you are not familiar with public housing residents, this information is from the 2022 HUD Resident Characteristic Report. So this is a report that is updated by HRSA almost every month. And so we have the latest information on public housing and the demographics of those living in public housing. There are over 1.5 million residents in public housing. Since this afternoon, we will be talking about people with disabilities and those who are over the age of 65. 38% of the household report to have at least one person with a disability, and 19% of the household reported to have at least a person who is over the age of 62. 36% of those living in public housing are children under the age of 17. 43% are African American, 52% are white, and 26% are Latino or Hispanic. Next slide, please. We are going to talk about diabetes in public housing and HUD-assisted facilities. And according to the latest report, that this one is also coming from HUD, almost 18% of those receiving HUD-assisted or HUD-assisted adults are people with diabetes. And when you compare that with other low-income renters, this is almost twice the rate of those with diabetes. Also, another big concern for this population are that 71% of them reported to be either overweight or obese. And for other social determinants of health and the other conditions related to this population, the percentage of those with COPD and asthma are also higher than the low-income renter population of the all adult population in the United States. Next slide, please. Today, we are going to have Zara Marcelian, who is the CEO and president of La Maestra Community Health Center. She will be presenting on diabetes and home-based care program that they have. Zara has been collaborating with the National Center for Health in Public Housing for many years, and she is the founder and president and CEO of La Maestra Family Clinic, an FQHC that serves approximately 45,000 individuals annually in San Diego County, California. Zara is an award-winning author and a well-regarded speaker and an international consultant. Zara also serves on numerous advisory boards. For more than 36 years, Zara has developed programs and services that meet the community's needs. Zara developed a holistic and solutions-based model to address overall health and well-being for all patients, regardless of their ability to pay. The model, known as the La Maestra Circle of Care, provides primary and specialty health care and social services to address the social determinants of health. Services include an on-site food pantry, housing, microcredit and micro-enterprise programs, job training programs, after school and summer programs, outreach, health education, environmental health, case management, and public program applications assistance. So it's my pleasure to just turn it over to Zara. Good afternoon, Zara.
Good afternoon, Dr. Leon. Thank you so much for having me here and letting me share what we have experienced with our pilot, our home healthcare pilot, and it's very exciting. So if we could just advance the slide, we can give a basic introduction. So as Jose described, La Maestra for over 36 years has been working on building programs that are really, I would say, important to patients' health and well-being. And how do we know this? Because of experience working with patients and clients and other programs, coming in the door and really seeing the number of needs, that they have layers of complexities. And it seems like, unless we address like their home environment or eligibility issues, immigration and so forth, patients will definitely benefit from a trip to the doctor. But I think that we have to look at it from a holistic perspective. And so that's why you see the different petals around this circle of care model represent groupings of services. So we have the mental health, behavioral health, we have imaging, specialty clinics, a lot, liver clinic, diabetes clinic, asthma clinic, hypertension clinic, and now the specialty for seniors as well. So altogether, we've found in our clinics that for every patient visit, there are numerous other visits around the social determinants. So whether it's coming to the food pantry, our immigration services, the human trafficking assistance, the youth programs, all of those together really bring the value to the patient towards their health and well-being improving. So if we could go to the next slide, please. As Jose mentioned, we have about 45,000 unique patients per year. Then that is 245,000 patient visits per year. We now have 21 sites in 4 of the San Diego County communities at City Heights, El Cajon, National City, Lemon Grove. And there's more than 55 languages and dialects spoken by, obviously, the patient base, which then we try to make sure that our staff is representative of. So the staff, 850 employees, they also speak these languages and dialects. It's very culturally diverse populations. And in different parts of the county, we have, different components, right, of those different cultures. Next slide, please. So this Today, we'll be talking about the diabetes care for Medicare home visits. We also have experimented with other pilots doing home visits around asthma remediation. Also, children having children, those were teens having babies. And we had a very successful program that was funded by the state. That program is now finished with the funding. But we really found that it was so beneficial to be able to do those home assessments. So when COVID, of course, was with us with higher rates than now with the surges, we saw that, you know, our seniors specifically were having a really hard time coming into the clinics. So we thought, well, you know, how else can we, you know, really open the access for them? So we decided, let's do this pilot and then try to piece together the funding to cover different elements. And as we go through the slides, I'll make sure to point out what was covered under grants, what's our PPS, and so forth, what covers, to kind of let you see how we pieced it together. And we're not finished yet perfecting this. And there's a lot of changes as we go along that we want to implement to keep improving our care during these home health visits. So transportation was obviously an issue. People were worried about, you know, trying to find the transportation during COVID, obviously. But now even, it seems that some of the seniors are really reluctant to get out on the transportation systems to go to the clinic. So we thought, well, let's start with, you know, a small group and see how it goes, how we're going to put it together. And of course, this also is addressing the seniors that have disabilities as well. So far in 2022, we had 234 visits for 120 unique patients. And what was interesting is that if we look at how many follow-up SDOH visits for those 120 patients and that were seen by the care team for the medical services and so forth, we see that our team has provided over 685 visits for, you know, like the food, for eligibility, for connecting the seniors with resources, case managing, doing like help negotiating with their landlords, because they're all in these low income housing that's, you know, kind of decrepit and causes a lot of challenges to people's health, as we'll see in the case study that I'm going to show at the end. So this kind of, I would say, is common, because if we look at our, you know, clinic patients that come in to our different sites, we see that for every patient seeking medical service or dental or behavioral health and so forth, there are, I think, another 4 to 5 average visits that those same patients will access other services around our circle of care. So this was important for us to note. So 53 patients with the diagnosis of diabetes mellitus, 25 patients screened for diabetic nephropathy, 21 patients were referred for routine diabetic retinopathy screening, 8 patients had foot exams to screen for diabetic neuropathy, and we plan to expand the current services as well as increase the number of Medi-Cal patients and duals, seniors eligible for home visits. Next slide. So the home health visit program integrates primary care, mental, behavioral health specialty services with the social determinants of health with cultural competency at its core. We can never, you know, like forget this, because it's extremely important that we're able to communicate with the patients, that our care teams, all of them, have access to translators to not only understand what's going on with them in their home environment, but how we can better incorporate resources to help them improve their health and well-being. So we started off with patients that had chronic conditions that have not been seen at the clinic within 60 days. And the care team is comprised of a medical director, specialty providers, mid-level providers, medical assistant, medical scribe, pharmacy, quality team, HEDIS team, medical case managers, and then you have the social determinants case managers and the health educator and the driver. And I wanted to say, we don't go out for every home visit with this whole team. So for example, the first visit could be with the providers and obviously their scribe, the quality team and the HEDIS. They don't go out to the visit, but they're part of that care team. The health educator goes, and then they call in the case manager for the social determinants to do the home assessment. And speaking with the caregivers and the family members that are there that are very much involved with that patient and their care at home. So by developing a comprehensive home health program with a dedicated team, we're able to assess, and monitor chronic conditions and, really pay attention to the quality of care that patients are receiving, not just through La Maestra's resources in-house, but also, as we refer them to other specialty services and other community-based organization services that they need, which of course speaks to the value of their care. Next slide. So we've been able to secure some grants and bring into this pilot the remote monitoring for the glucose monitoring and as well as the blood pressure cuffs. And that's been interesting. I think that, overall it's very well received. The success depends on how much the patients and the family that are helping them understand how this works. So we spend a lot of time doing the basic health education, but really, if, for example, somebody has a blood pressure cuff, really spending time making sure they understand how to care for that, blood pressure cuff, when to take it off, what's going to happen, the nurse is going to call them, how that all works, and why we're suggesting that they incorporate this remote monitoring. And we're still, tweaking with it, and hopefully our grant lasts long enough to build up some good numbers to be able to go back and assess, how much difference did all this make. And but we're seeing some good results so far. We have in-home podiatry, and we seems like we're having to contract with outside providers as well for podiatry, so they can come in, and with the diabetic patients, especially important for the foot exams, the nail clipping, neuropathy, any ulcers, any infections that patients are experiencing. And that has been a really beneficial service for the seniors in their homes. Again, the diabetes health education in numerous languages is super important. Again, patients need to understand, what the glucometer does, how to use it, and what actions to take when the results are high or low. Also to describe, what insulin is and why they need it, how it works, and what to do if, again, their readings aren't working. They need to know like who to contact, what to do. Very important. Glucophage as well. Diet is super important, since many of our patients come from these culturally diverse backgrounds. We found it very helpful to take some basic recipes and try to convert them into more nutritious, recipes for them, while they can still keep their traditional dishes. So, not using so much salt, not using so much, butter or lard. Those are just small examples. And foot care. That's been what we've seen has been like really important so far. Next slide. So the family caregiver support. We've been to cases at homes where seniors are living by themselves. Most of the time, they live with family members, and they're very low income, and they really depend on somebody in the family that's taking care of them being able to receive the county's assistance for, they used to call it, and now it's called in-home care provider, and it used to be in-home companion. And so the county does an assessment where they figure out how much time does the patient need assistance and for what level of assistance or care is needed. And they will pay for certain many hours per week for somebody to come in, do some light cleaning, cooking, and helping the patient with their, bathing and so forth. So that's really important to these families to be able to make sure that whoever's there helping them gets that pay, and it adds to the household income. So that's something that we do help them with for their eligibility. We do a lot of case management around eligibility for many resources, translation. We deliver the pharmacy, the medications to their homes. We provide diabetic education to the caregivers that are there with the patient in the home. And our labels, I wanted to say the labels on the medications are also in the different languages. That was quite a challenge, but we're almost there with most of the languages. And so then I talked already about the inner home health services. We also spend a lot of time with the patient and their caregiver around the storage of insulin. And you'll see in the case study an example of why. We do an environmental assessment, and we try to figure out, is that house weatherized? Are they having ventilation problems? Do they have heating? And so forth. So resources for housing assistance, food scarcity, and social services are a major part of what we do during the home visit. Next slide, please. So now I wanted to talk a minute about the access to La Maestra specialty clinics and services. These are at our clinics. We currently have specialty clinics, including diabetic clinic, hypertension, liver, asthma remediation, senior medicine. And then we have other specialists that work with us, and then there are those that we contract with, and we have them come into the clinic sites, once a week, depending on what the need is. And that's for endocrinology, cardiology, GIT, internal medicine, geriatrics, podiatry, and ophthalmology. Next slide. This is a sample of, one of the first flyers that we designed for our home health program. What else is going on in that part of the county, in East County, is that some of the FQHCs have put together or collaborated on case programs, and that works for, that's the adult daycare program. That works for a lot of people. I think it's a good model, but for our populations that are refugees, immigrants, and from different cultural backgrounds, they do not want to be taken out of their homes every day to a facility that they don't know. They don't know the people there. They don't speak the language. The food that they're served isn't familiar to them. And then they also would lose their in-home companion care, right? The funding that comes in through their caregivers, which oftentimes are their family members. So they don't choose really to participate in the PACE program. And when if they sign up for PACE, then they usually have to change their providers and their pharmacy and on and on. So it's kind of disruptive to people who do not enjoy leaving their homes every day to attend adult daycare. So this is another option that we offer where people can stay in their homes. We connect them to other resources, and, for, social activities outside of their home, we do ask, do they attend any functions in their community? How big is their family? Does their family live close by? To see what kind of support they have and how we can integrate them then into some senior activities that we offer, via, online, where we've done, like, especially during COVID, we would do, the senior in-home bingo online. We have like chair yoga classes online. We have the cooking for specifically for diabetes and other conditions. We have those kinds of videos that we post, and actual support groups that meet online. And we started that during COVID. We've continued that as well. So it's really making a good assessment of what's happening with that person in the home and who's there, what kind of supportive network they have. Next slide. Our senior case managers around La Maestra Circle of Care model are utilized for internal and external referrals, and they navigate the seniors' needs. Regarding HEDIS and the QI, we've developed a matrix that's monitored by our QI director, the team, as well as the HEDIS team and the medical director, to evaluate the progress and effectiveness of the program. This is a pilot, so we're continuously looking to see, okay, what worked? How effective was this intervention, or by adding somebody else to the care team, and just see how the response is, especially since we do utilize hybrid models for even when, let's say, the care team's doing a follow-up and a follow-up visit to the home, and they want to connect with that provider back at the clinic. They do that through the telehealth as well. So it's really interesting to see the different modalities and how they integrate and what works. Currently, La Maestra's East County Clinic has the following Medicare patients enrolled in the healthcare program. This is the home health, the whole home health for the seniors, not just the diabetes. And that would be the seniors 50 years to 65 years. There's 90 patients. Seniors 66 and over is 619 patients. Again, this is for the overall home health care for seniors, not just the diabetes. Okay, next slide, please. These are the HEDIS measures that we are tracking for the seniors. Use of high-risk medications in the elderly, potential harmful drug disease interactions, if the patients have dementia, what other resources are they connected to, and trying to make sure we have some good communication with their care team around that. Adults access to preventative ambulatory healthcare services for 65 and older, care for older adults, advanced care planning, transitions of care, medication reconciliation for the post-discharge. So when they've been in the ER, the hospital for any period of stay and they come home, how can we better help them through that transition and help them monitor and make sure that they're not going to end back up into the hospital with the same issue. I'm not going to read all of these, but you can see we do screenings for depression, follow-up plans for adults. We do assessments, for the BMI, and there's just a lot that seems to, for preventative care, making sure that people have had all of their vaccines, if not, make that available to them, give them that health education, not just around COVID, but around the flu vaccine, shingles, and so forth. Next slide. So this is a case study I wanted to share with you. And then we'll get back to some of the reimbursement models that we've experimented with and what seems to be working out. So we had a female diabetic patient. She was Latina, lived by herself with an A1C score of 11. She had missed appointments at the clinic and she was non-compliant with the medications. She wouldn't get her refills. And basically the team was concerned about her. We did the home visit. And what we found out was that the patient was homebound because she couldn't maneuver her walker, and she had a walker with the tennis balls, and in the front and the bottom. And from her front door to the street, there was very uneven pavers. And so she couldn't really navigate her way down to the street with this walker. We found that she didn't even have a refrigerator. She was using an ice chest to store her insulin and food. So again, that was a big concern because the insulin wasn't being stored at the correct temperatures. And her cottage that she was living in was very run down. She had no transportation. She lived by herself, and she didn't have any family members close by. She had one daughter, but the daughter was across town and worked many hours a day. So this elder lady didn't feel like she could call on the daughter for help or support. So, and like many of our patients in housing, low-income housing, they're very fearful about contacting the landlord about anything that doesn't work in the place. They're worried that right away their rent is going to be increased or they're going to be evicted. They don't know what else or what other options they could have. So again, this patient was worried about these same issues, and she had not mentioned anything to her landlord, about the other issues in the house, the plumbing and so forth. So what we were able to do in terms of interventions was to, first of all, do this assessment, contact the patient's health plan, and ask about, what options, resources that they could help us with for this patient. And they provided the patient with a mini refrigerator to store the insulin, which was awesome. Our case manager contacted our local utility company, San Diego Gas and Electric, and we were able to enroll the patient in the CARE program, and that's for utility discounts for seniors and people with chronic conditions. Also, weatherization of windows and doors through another program, and that required the permission of the landlord, who didn't want to get involved, didn't want to be reported because he was renting out substandard housing and not fixing things that really did have to do with health and safety issues. So we convinced him finally, and the letter from her provider at La Maestra really seemed to work. And it was, a nice letter, and it was encouraging. It's, basically saying, this patient's under our care, and we've determined that, these remedies would really help a lot. So we'd really like your, cooperation, because we needed his cooperation in order to bring in the partner that did the weatherization for the windows and doors. Our care team arranged for medication delivery from La Maestra, so the patient didn't need to go into the site. And of course, we offer in-home deliveries for all of our patients throughout San Diego County. Our case manager coordinated with La Maestra's food pantry to deliver, food items to the patient because she couldn't go into close by food pantry. We also connected her with the Meals on Wheels, and the case manager helped enroll one of her friends that was in the area to, with this county in-home support program. So she could have somebody that she knew come in to help her with basic light housekeeping and cooking needs, and kind of monitor to make sure she's okay, right? So the result is the patient is now compliant with the visits to the clinic and the medications. By the way, we got the landlord to make that path more clear. He removed the pavers so she could get down to the street with her walker, which means now she's exercising more, she's walking more, she's getting out more, and now she's actually coming in to the clinic for some of her visits. So that was awesome. And her A1C level dropped to 8. And she reports being much happier. She seems to be more upbeat because now she's able to connect more, socially, and physically, she's more active. She's not homebound anymore. And she now has these resources. And of course, our case management continues to monitor these patients that are in the home, even when they are, really doing better, because they are, aging populations, and other things happen with their health and their life and their outlook. And we want to make sure that we can bring those resources to them and get them more mobile, and help them through these transitions. And we connect with hospice, we connect with many other programs in the community that can really address these other issues. Next slide. Oh, so before we get to the questions and answers, I did want to go back to the reimbursement model. Well, there's no fixed reimbursement model right now. We do get reimbursed, obviously, for our at the PPS rate for the medical visits for these patients. Everything else we have to piece together. So under some of our managed care contracts, since now California has transitioned to CalAIM, value-based model, and is having the managed care plans reimburse for some of the social determinant services beyond the medical visit, we're able to pick up some reimbursement for like the food, the housing assessments, and other elements of the visit. So that pieces together some, it covers some of the staffing. And then the grants, that's the other piece, like for the remote monitoring, telehealth as well. There's some grants for that that we've been able to take advantage of. We have not been able to secure funding through grants for our diabetic clinic as it relates to going into the home for the home visits. We're working on that. We have picked up some good grants for asthma remediation for our home visiting program, which is different than the one I presented here today. So it's about, like everything else we do, piecing together, asking for grants, asking for donations, working with our other for-profit partners in the community to see if they would like to support this in-home health program for seniors. And that's what we continue to do. And whatever the shortfall is, we make it up with our operational budget until something else comes along. And hopefully this program can, become totally sustainable. But it seems like that, the number of services that we're bringing into this care model, aside from the medical and, behavioral health and dental and so forth, that can be reimbursed. It's tough. It's like trying to weave together a tapestry, and hopefully that, that model will become sustainable as more social determinant services are reimbursed through the health plans. Okay, so I think that's about it. I also wanted to say that, La Maestra has a huge, seems like huge transportation fleet right now that we do patient transportation, not only to our clinics, but also to specialty services appointments that, are not at La Maestra. So that hopefully can also help a lot with the seniors at home. Thank you so much, and I look forward to your questions.
Thank you, Zara. Next slide, please. If you have any questions for Zara, please, you can use the chat box that is either at the bottom or at the top of your screen. Please type your question, or if you have, you would like to ask Zara a question verbally, we can unmute your line so you can ask her your question. Zara, this is a great program, a great pilot. I'm very glad to see, how the A1C of the patient came down, from 11 to 8, and the person was able to interact, and exercise in the community. That's fantastic. Before we get some question from the audience, Zara, I do have a question for you. Have you seen, or has your team seen any advantage or disadvantage between this pilot and the telemedicine services that you provide?
Definitely, the team has commented on this kind of hybrid model where, they're able to go to the patient's home and then do follow up and also incorporate that telemedicine element, the telehealth element. So perhaps the next visit or the third visit, the care team's there, the provider maybe isn't there, and they can connect with the provider while the provider's still at the clinic, and do that consult right there with the provider. So that brings a lot of flexibility to to our team, and bringing in resources for that patient, because obviously we cannot show up to that patient's home every time with all of these staff members.
Yeah. Okay. Thank you, Zara. That's great. Before I forget, at the end of this activity, there will be a poll or a survey. Please complete the post-webinar survey. We appreciate your any feedback that you can provide to the National Center for Health in Public Housing. Let me see if there is any questions. I don't see any questions. Again, I mean, if you have any questions, you can use the Q&A feature or the chat feature at the bottom of your screen, or if you would like to ask the question verbally, your line will be can be unmuted.
I wanted to say also, Jose, that we bring in our own equipment. We know that many patients are not going to have laptops and so forth, and even the Wi-Fi. So we have figured that out and been able to make sure that we're able to connect from wherever we are.
That's great. And Zara, that brings another question. Have you? Is my understanding that the public housing program is a bit different in the San Diego County area, but have you? I mean, are there any partnership either with the housing authority or the other community organizations to keep this pilot moving?
Well, obviously, we have let our partners know, the Affordable Housing Commission, let them know of our services and what we're offering. And they're great about, sending out to their residents, our new services, programs, updates on COVID, and so forth, informational items. But they haven't really provided any assistance, funding wise. We definitely are keeping our eyes open through CDBG, which is the HUD funding that comes into San Diego for services and for capital expansions. And we have a great working relationship with the county and HUD. So whenever we can, we do apply, and that's how we were able to, for example, build out our imaging unit, build the full, DEXA scan there, and then our mobile mammography and the fixed mammography, and on and on and on, all ultrasounds and so forth. So we've got a great partnership there, but this is really service related, doesn't involve any build outs. And I know that they do have the service related grants, and it's just that we apply for those for our other services as well. So I don't know how much we could extend that to include the home health services through HUD, but definitely they're aware of it. And I'm hoping that with more advocacy around this model, perhaps they would be inclined to fund part of it. So, again, we just keep looking out to, our different funding sources, our partners, our donors, to see if they, really want to focus, or their priority this year is on the aging population. And this presents a different way to access care and bring those resources into people's homes that otherwise, like this case study, this poor woman was living by herself and, in very substandard housing, and really didn't know what resources were out there or how to connect to them, which is the huge piece. And I think that's one of the big benefits we bring in through our program. And yes, San Diego is on a different model. We do not have a lot of, public housing or projects, units. They stopped building these many years ago, and instead there's subsidized housing in different neighborhoods where landlords can sign up with the program, and they can basically get subsidized for the rent, and for tenants that are enrolled under Section 8 affordable housing and so forth. So that makes it different for San Diego, but definitely we're in all of these communities, in these low-income communities. And so housing is a huge issue in terms of the challenges it presents to patients and their health and well-being. And that's what we're trying to help them with.
Thank you. That's wonderful. My next question is, I would like to put some of the pieces together, and in the very beginning, we discussed the number of, or the percentage of households, reporting the number of patients with disabilities in public housing or their senior population. Very large percentages of the people, are living in public housing are either disabled or over the age of 62. This is by HUD standards. So there would be, in the future, there would be, the need to expand or to improve or increase these type of services.
Mm-hmm.
Where do you see this program, this pilot, going? It's very difficult to forecast, what the future will be, because everything depends on the grant money that you receive and the resources that you have. But what do you think the needs will be in the future, and if there is any plan, for La Maestra to continue this program?
Well, definitely the plan at La Maestra is to continue building this program. We started in East County because that's where we had predominantly seen more seniors that are not accessing the care at the clinics. And their needs, though, are the same as seniors in other parts of the county that we serve, because they're all low income areas. And that means that, yes, they come in and they're experiencing issues with their, substandard housing arrangements. They also face transportation issues. They need to be connected to, food scarcity programs, social interaction, a supportive network. So our hope is to replicate this program once we get it built out more and bring more resources in that are more sustainable. And then we can go to the board and say, look, this is what we've been doing here. Of course, they know about it. They give us our approval. But can we replicate it? Can we, roll it out now in City Heights or National City or Lemon Grove? And so I'm really looking forward to that and bringing more resources and partners in.
Excellent. Thank you, Zara. Fide, do you see any questions from our participants?
No questions at the moment.
All right. Next slide, please. So again, all the resources, the link to the recording and the slides will be shared with all participants. You can also visit our website, nchbh.org, and you will find additional information on all the training and technical assistance activities that we have for all health centers. Next slide, please. Also, you can contact our team. If you have any additional questions, you can either contact Fide, who is behind the scenes, or you can contact me. Our contact information is here on the screen. So in case you have any additional question for Dr. Zara Marcelian. And Zara, thank you so much for the opportunity, and thank you so much for sharing what all the good things that La Maestra is doing in San Diego.
Thank you so much. Really appreciate this opportunity, Dr. Leon.
Thank you, and have a great afternoon.
Thank you. Bye-bye.